Right, our next speaker is Dr. Gideon Koren. And just a brief introduction, because I'm sure that everybody in the room is well aware of Dr. Koren and the work that he's done. Gideon is a founder and director of the Motherisk program, a well-known program in Toronto, internationally renowned. He's a professor of pediatrics, pharmacology, pharmacy, and medicine at both Western in London and the University of Toronto. And he's a staff pediatrician at Sick Kids in Toronto. Dr. Koren is the founder of the FACE, Fetal Alcohol Canadian Expertise Network, and the peer-reviewed journal of FAS International, now the Fetal Alcohol Research. So I could keep going on and on and on and on, but I think I'll stop there and welcome Dr. Gideon Koren.
Thank you, David. I want to thank Betty Ann and Carole Boyer for putting a lot of effort into this meeting, and I'm gratified that although this is an afternoon of a Friday in a meeting, but the document produced for this will be available forever in the peer review literature and also hopefully for government and regulatory agencies. I'll try to be more clinical and to put some context to why are we talking about this. So my objective is to describe kinetic changes in pregnancy that may affect drug use and to present several cases highlighting why is this relevant. And I'll cover the following points. That we often talk about absorption, distribution, clearance rates, bioequivalent. The most important variable in drug use is adherence, compliance. So I'll go and talk about this first. Here's a case. This is a 28-year-old woman with moderate to severe asthma. She would put on, at 8 weeks of pregnancy, on Montelukast. She discovers later she is pregnant, not unusual. Do remember only half of pregnancies are planned, so she happened to be among those who did not plan pregnancy. Once she finds out she's pregnant, she's scared. She's scared herself, family members, and some women magazines that she reads tell her that drugs may be bad for the baby. So this lady, this is a real case, by the way, discontinue her medication at 16 weeks of gestation. At 19 weeks, she is brought to an American emergency room in a severe attack because she is not treated. She dies 3 hours later from respiratory failure. So this is what it means, variability, what pregnancy means. Well, since the thalidomide disaster, most of you, all of you know, this very high level of perception of teratogenic risk. Everyone says every drug may cause malformations, so women should not take anything. Well, in reality, as you know, very few drugs cause malformations, and other are not, and quite a few we are not sure. But of course, the thalidomide, while it started the field of teratology, it also put a huge figment that women should not take medications. Well, so imagine a woman finds out she's pregnant. There will be always someone who will tell her, that's not a good idea. In pregnancy, women becoming a public domain, everyone tell them what to do, mostly without checking for what's known. Let me now bring it down to earth. Very often in Motherisk, we get counseling of women who suffer from depression that were told not to take their SSRIs or SNRIs. Often they stop the drug, although doing well, with the cost of deeper depression, hospitalizations, suicide attempt, and sadly sometimes success in suicide attempts. So this is the cost of misperception, especially that the SSRIs overall are relatively safe drugs. And clearly the risk-benefit ratio is very clear. Now, even closer to home to Motherisk, we are doing in Motherisk a lot of studies on vitamins in pregnancy, part of other studies we do. We often recruit women who want to participate. They are proactive, they are volunteering. And we give them medications. For example, here in this case, prenatal vitamin. You would think that they will take it. They are in a study. Well, we ask them to bring back the pills and their diaries. What's the average compliance? 53%. Going from 0 to 100%. So if these women who came forward to participate have a 50% usage, what's the usage out there? Much less. I'm bringing this up because this is a pharmacokinetic variable. If you don't take your drug, I don't really care about your pharmacogenetics, about formulation. You don't expect a drug not taken to do the job. There are many other examples. For example, there are vitamins which are horse pills that women are supposed to take in pregnancy. But if they have morning sickness, how are they supposed to take them? And indeed, they do not. We show that the size of the molecule of the tablets affect it too. So I just want to bring to your attention, because very often pharmacokinetics mean for people absorption, distribution, elimination. Not true. This is the biggest variable in kinetics, whether people take the drug, what caused them not to take it, and what we as physicians should do to improve it. In general, when we teach pharmacology, we tell our students, medical students, postgraduate students, that when a patient sits across your table, always assume that the compliance is not more than 50%, and think, what am I going to do to increase it? That's how severe it is. Adherence, still. Many women cannot hold, when they have morning sickness or nausea and vomiting of pregnancy, cannot hold down their antiemetics. So the small size I mentioned, another point is iron content. Many of the prenatal vitamins have iron in them. And iron is very irritating to the GI. When you have morning sickness and on top of it someone tried to irritate your bowel, you're not going to have good compliance. You have to know that. This is especially important when adherence cause lack of response. Go back to my case, tragic case of the woman with the asthma. But that's only one. Doctors often give women much lower doses because they're afraid to be sued and forever, and the women on top of it take even less. So a lot of women are treated with homeopathic doses. This will not generate any particular good effect. Well, it means that we need to counsel women and empower them to take the medications when they need it. Otherwise, they will not get the effect. And that's why women are so commonly orphaned from the benefits of drugs. Because people kind of telling them, you are on your own, pregnancy on your own. I don't know what to tell you. I'm afraid to be sued. Come to me back after pregnancy. Not a good idea. Absorption. There are issues of absorption of drug. First, and most importantly, many women delaying now starting a family. So it's not unusual for women to have the first child at 30, 35, 40 and up. Guess what? The older you are, more likely you have a chronic illness. Inflammatory bowel illness, just as an example, can go up to 5% of women at the reproductive age. So these women will not absorb drugs necessarily as you have thought. So the role of the condition itself need always to be considered. So impaired absorption of nutrients, of vitamin B12, and potentially of medications due to chronic conditions of the bowel. We mentioned already nausea and vomiting of pregnancy. It's not unusual for a woman to tell us that because of the stagnation of her gut, if you wish, she can vomit what she ate yesterday. So why do I even think that the drug will be absorbed? I gave her a drug for hypertension, for diabetes, for whatever. It will sit there. This has important implications for kinetics. So anyone who studies kinetics in pregnancy, efficacy, must address the risk of nausea and vomiting of pregnancy, because 80% of women will experience it. What does it do if the gut does not propagate itself forward? So the question is, what's the extent of delayed absorption of medicinal drugs? And of course, the second thing, if a woman took her anti-epileptic and she's vomiting 20 minutes later, how much of her dose really is still around? Should we replace it with another dose? So interestingly enough, in cancer chemotherapy, there are some rules. It depends when you vomit, how much to give you. Not so much in pregnancy. That type of language we don't hear much in pregnancy. It's another area that we must consider when we counsel or trying to design drug dosing for women. Distribution, of course, drug is absorbed. The drug is distributed into its volume of distribution. To remind everyone, volume of distribution is never an anatomic place, except for one type of drugs that stay only in the blood, such as large molecules, say immunoglobulins. Their volume distribution is the volume of blood because they don't go anywhere. But for most drugs, they go to different places, which may correspond to total body water or any other compartments. And of course, concentrations are, by the simple Fick phenomenon, is the ratio between the dose and the clearance rate. In the third trimester, there is a decrease in serum albumin, a physiological one. So drugs which are tightly bound to plasma, say propranolol, above 95%, Coumadin, 98%. Less binding mean more drugs going to other spaces, larger volume distribution. So these are important considerations. And sometimes, although not routinely, we may want to consider it in our calculation of dose. The one error that many people do, they think that if the volume of the body is larger, you need higher dose to maintain the same steady state. This is not true. The only thing that affects steady state level is the dose per kilo divided by the clearance rate. So the original or the initial distribution is just the time that it goes everywhere. Then the dose is not affected. So a woman who is now larger, because it's third trimester, may need higher dose because per kilo she received less. But if her clearance rate did not change, she may not need more dose. And that's why we need to be personalized, and we need to know about that woman as close as we can, based on her disease state, based on the drug, and based on the changes in her body. Again, medications were not meant for healthy people. So if a woman has nephrotic syndrome, her distribution of drug may be very different, or a woman after transplant, than a woman who does not have those issues, and so on and so forth. So what I'm trying to say, while Health Canada and FDA and MEA are interested in averages, and that's where bioequivalence of 80% to 120% comes from, in pregnancy, there's the pregnancy and the disease for which you give the drug, which you must put into your considerations. Otherwise, you may under or overdose women. The big thing that was investigated in the last 2 decades in pregnancy, more than anything else, is the elimination. There is more and more acknowledgement that in late pregnancy, namely mostly third trimester, several cytochrome P450 are more active. Their activity increase, which means that the elimination of certain drugs, which are substrates to these systems, will increase. Increased clearance rate means lower steady state concentration. It's like your bath that have an opening. The opening is now larger. You need more water if you want the same level of water in your bath. So here are some examples. 3A4, clearly there is an increased activity, up to 2, sometimes 300%. What does it mean clinically? If a woman is treated for HIV/AIDS with protease inhibitors, the dose she received before pregnancy will be inappropriate. She may need 2 to 3-fold larger dose at times. Midazolam is another example where, because of activity, women may end up needing more. And I just give some examples. I don't want to give you, A to Z, all the drugs. It's meaningless. It's more the principles. The same with 2D6, fluoxetine, other SSRIs. They will be metabolized more. But don't take that necessarily that the woman may need more drug. Because if the metabolite is active itself, then she ends up with more metabolism to an active component. For example, sertraline, venlafaxine is a very good example that the drug itself is metabolized into an active metabolite. So although there is more metabolism, she may not necessarily need more drug. Another very important example is the nicotine with 2A6. Why? Well, nicotine is metabolized more in late pregnancy. Neil Banowitz and his group in San Francisco showed it in repeated studies. What does it mean? If we try to treat women for smoking cessation with nicotine patch, she may need more dose. And interestingly enough, most studies studying cessation in pregnancy failed to show effect. It may be because the dose was not appropriate and much larger dose is needed. People said, hey, something is strange about pregnancy. Women do not respond. Maybe they respond, but they need more drug. So the nicotine replacement is one example where this is important. The second, every woman wants to stop to smoke in pregnancy. Many cannot. It's an addiction. One reason may be because there is more metabolism of nicotine, so she needs to smoke more to maintain nicotine level, because nicotine is what we are seeking when we consume cigarettes. But you see, even the activity of cytochromes is not generalizable. There are other cytochromes which decrease their activity. And some of the most studies, actually, the first study I did in Toronto in '82 was young people, women, adolescents, who took oral contraceptives, which in a way is like pregnancy, to show that the metabolism of caffeine and theophylline decreased. So women in pregnancy will eliminate caffeine and theophylline more slowly because the 1A2 is inhibited. The same is with phenytoin, with 2C19. So you have to be very sensitive for those. Women may become poisoned with the dose she took before because there is decrease in metabolism. Interestingly enough, we still don't know the mechanism for these changes. And just to show you how women are orphaned in pregnancy, the one thing that increases in pregnancy for sure is GFR, 50%, and hepatic blood flow. Go to PubMed and find one reference for the change in hepatic blood flow in pregnancy. If it's positive, I'm invited you for dinner. No one ever did such a study in humans. Isn't that ridiculous? Isn't that ridiculous? Every drug is metabolized to some extent, or most drugs, by the liver, even digoxin. But no one took the time to do non-invasive studies to show the increase in blood flow. And that's, for me, if you want, a marker of the status of women. There's no excuse for that. How about GFR, glomerular filtration rate? GFR increased by up to 50% in pregnancy. And naturally, that means the drugs eliminated by the kidney or metabolites eliminated by the kidneys will leave the body more quickly. And some examples, women who are treated with lithium or women are treated with digoxin may need higher dose. By the way, the same is true for some of the drugs I showed you with the cytochrome. So it's not unusual for a woman to come to Motherisk afraid of taking a drug, and we tell her not just not to stop, we also tell her that she may need higher dose in late pregnancy. So levels should be measured if it's measurable, or if it's a drug which is not routinely measured, say SSRIs, we always tell the woman, you may need more drug in pregnancy late. So if you feel the symptoms coming back, remember that, and we write to the physician too. You may need higher dose. And vice versa after pregnancy, she may need decreased dose. So you see, these are very important implications. It's not just submitting to FDA or Health Canada. These are all points that affect human's life, women's life. Now, everyone talk about GFR, but I want to remind you that many drugs are eliminated by the kidney, not just by filtration, but also by active secretion by the tubule itself. And there are changes in active secretion too. For example, the most studied transporter is the P-glycoprotein, which is responsible for many substrates, for example, digoxin. Almost all the body load of digoxin go through the kidney. Most people say, sure, GFR, not true. Tubular secretion of digoxin is higher than GFR. So if there's increase in P-glycoprotein in late pregnancy, it's another way how drugs are eliminated. And that should lead to increased dose. Now, I want to remind you that quite a few drugs are metabolized to active metabolites or toxic metabolites. Example, morphine. Morphine is glucuronidated to 6-glucuronide, which is much more active than morphine. So, not surprising if GFR increases in 50%, although morphine itself is not filtered, the glucuronide is filtered. So if a woman has less effect in late pregnancy, this may be because of the glucuronidation. The glucuronide is excreted more quickly. And of course, the opposite after pregnancy. If a woman needs meperidine and her GFR falls dramatically, the non-meperidine, which cause toxicity and seizures, may accumulate. So always think not just about the drug itself, but how the metabolite leaves the body. And we don't do this enough in our practice. I want to give you an example how complex this is. This is a paper published, two papers back to back in the American Journal of Obstetrics and Gynecology, one of the most widely read journals by obstetricians, pharmacologists, gynecologists, and physicians like myself dealing with the area. Two papers back to back. Beigi et al. Looked at oseltamivir, of course, Tamiflu, which becomes very, very popular in the last few years with the outbreaks of influenza. So they wanted to compare pregnant women to non-pregnant women. They looked both at the oseltamivir, which is a prodrug, is not the active drug, and they see no differences in the area under the curve, namely systemic exposure unchanged. But look here, the active metabolite, the carboxylate, there is significant decrease in levels, which means it's secreted from the body more quickly, which means you should use larger doses to get to the same effect. Alas, in the same journal, page after page, there's another study by Greer. They did not compare pregnant to non-pregnant. They compared 3 groups by trimester. 10 women first trimester, 10 women second, 10 women third. And the same people don't find such differences. The metabolite is the same. You see, first the design is not the same, it's before and after. But what are physicians to do with those two results? And as Professor Lalonde said before, only 10 per group. Who said it's enough? Maybe you need more. Each of these studies need to have a power calculation to show us why they use 10 and not 20, not 30. So at the present time, although many years of work were conducted in these studies, we cannot come to conclusions yet. And I'm not cynical. This is the way science goes. And we need more work. So here's a repetition of what I told you. Pregnant patients need to be aware that in late pregnancy, she may need higher dose of a medication. Many women find it counterintuitive. The physicians told them to stop their drug. They come to Motherisk. We tell them to take the drug and to take more in late pregnancy. So unless you communicate this with a physician, there will be oftentimes a lot of mistrust. And it's not easy, but that's the way it goes. And whenever women have increased symptoms, you cannot predict upfront the differences among different women, because there are variabilities not associated just with pregnancy, also personal variabilities in, for example, genetic polymorphism. Is she ultra-rapid metabolizer of 2D6, or extensive metabolizer, or small or slow metabolizer? But the minimum you can tell a woman that if she has symptoms coming back, or if she has toxicity, to be assessed. And that's the meaningfulness of personalized medicine. I want to spend 2-3 minutes on novel methods, how to learn on changes in pregnancy. One thing you can do is to bring a woman first trimester, again second trimester, third trimester, put a catheter into them, give them a drug, let them stay in your clinic for 24 hours to measure drugs repeatedly. You will not find many patients in pregnancy that are ready to consider your offer. Oftentimes there's another small kid at home, she's working, she has life. But here is a new method that we developed with the help of some European colleagues. Hair grows 1 centimeter per month, and drugs grow into hair if they're in the blood. But not just the drug grow into hair, also the metabolites. So levels in blood, in hair can tell you the metabolic ratio of specific drugs. And let me show you how it works. So for example, we did it with nicotine. We took women, and because most women have up to 20 or 30 centimeters of hair, you can section month by month, and we were able to show that in late pregnancy, there's much more cotinine to nicotine than was in the first pregnancy, because there's increase in Y1A2, and that featured exactly what Neil Benowitz showed. He did bring women in and took many levels. The beauty of it is hair is non-invasive, and you can get population kinetics. You can get many women to see not just the change, but the degree of change among different women, and maybe correlate it with genotype. So this is a new method that one can use. Let me show you another example. The drug venlafaxine has become, in the last 7 to 10 years, the drug of choice for depression in pregnancy. After Paxil left the stage for the wrong reasons, venlafaxine took over, Effexor, as you may know it. Let me show you. That's with the help of some colleagues in Europe, forensic scientists who can measure very small concentrations of venlafaxine in hair. What I show you here, first, blood. This is one woman that agreed to come to our clinic, and this was done by Dr. O'Brien now. Issa O'Brien, who was my graduate student. The woman took the same dose in the first trimester and in the third trimester. Look here. In the third trimester, her blood levels fell almost in half. Assuming that she took the drug and we watched her taking the drug, it means either decreased absorption or increased clearance rate. And the area under curve followed the Cmax. And look what happened to the metabolic ratio. Metabolite versus parent drug. It went from 0.9 to exactly double. So double metabolism caused double lower levels. Here's the hair of this lady. Here's the metabolic ratio at 3 months of pregnancy. Then in the second trimester, look how much more metabolite. Third trimester, and that's from her hair of that lady. And that's postpartum. Here's she postpartum. It goes back. So see how much you learn from hair without the need to bring her to clinic for so long and all that goes with that. Here's case number 2. In a way, I repeat what you heard from both Dr. Lalonde and McGilvray, but I'll do it a little bit more clinically. Case 2, a company wishes to introduce a genetic form of a drug for treatment of pregnancy for pregnancy-induced biliary cholestasis. This is a terrible pruritus and should be treated. They want to compare their drug to the available compound on the market. They recruit 20 men to study bioequivalence. But no man is going to use the drug. The company claims, as does unfortunately the regulator, say, although men and women may be different in absorption and clearance, the comparison of the two compounds in the same individual make it legible. It's fine, because it's the same body. So we'll look at, yeah. But as you heard from Dr. McGilvray and Dr. Lalonde, this is true only if the variability between those two groups, women and men, is the same. If the variability is not the same, then you don't know. And indeed, the Chen study, quoted by both speakers, clearly show that for many drugs, the variability is very different between men and women. So why can I assume that a new drug, for which I don't know the variability in men and women, will be the same? How can I? A claim could have been ethical. You cannot study women. Sorry, we're not talking pregnancy. We're talking healthy, young volunteer women. Why can't you use them for a study that would lead to drug? Do you take women to study a drug for prostate? No one. Or for erection? No, no one do it. So I think this is something that stayed from an old system, and I don't think we should accept it. Absolutely not. There is no reason under the sun why men should use. The worst is not even when people use only men. They use a mixture of men and women. But if the variability is different, then if you take half and half, it will be different than if you take 1/3 and 2/3. So actually the results will be all over the place because you use different proportions of men and women. And that should not be accepted. I don't think Canada should allow that. Last but not least, very, very briefly because of time, is the issue of pharmacodynamics. And I will just give you one example with more details. Several studies have shown, for example, that women are more depressed in the first trimester of pregnancy, and no one understood why. Till a group in Detroit showed that it corresponds to the time of the peak of morning sickness. Women with morning sickness are depressed because they feel terrible. So it's a pharmacodynamic effect. It's nothing to do with levels. It's because there's another reason for women to be depressed. So unless we calculate that into our work, Kinetics by itself is not the end of the story. We treat people, we don't treat volume and distribution. So in conclusion, therapy should be individualized as much as possible, addressing kinetic changes in the context of dynamic alterations due to the medical condition. And the example, last example, is morning sickness. If you have reflux, if the woman have a tendency toward reflux, her morning sickness will be much more severe. So it's not that her drug doesn't work, but she has another confounder. Thank you very much.
Are there any questions for Dr. Koren? I'd just like to ask about the hair. That's fascinating. I have two questions. First of all, where do you cut the hair from? Like if you want the last month, is it right next to the scalp or is it out here? And second question is, you mentioned two drugs and some Europeans. How far away is this from we can use it for different drugs, for more drugs? And maybe do it collaboratively across the country, for example.
Sure. Well, the first centimeter reflects the last month because it's the closest to your skull. The next centimeter is 2 months ago, 3 months ago, up to how I don't have much hair. It's a handicap, age dependent. But women luckily have hair. So you don't pluck it, you cut it near the skull. Important enough, when it comes to the lab, we need to know which side it is. Often it's easy to say. It's easy because women perm their hair, they put colors on it, you can tell. But it's still better to tell us which end is what, and we couldn't section it as much as we ask the question. Now, this area, as you realize, David, is moving forward by forensic scientists who have to decide why people died. They were the first to look into hair. We adapted it for children and then for pregnant women. But really the science is moving. So my team, Katia Alexa, Joey Guerreri, and our students are going to forensic science meetings because that's where we learn the science of it. In Europe, several labs came to so much sensitivity that they can do what I showed you with the venlafaxine. It's just that we don't measure routinely venlafaxine. So much so, you know that one of the biggest epidemic now is day rape, that people drop into women's drinks a short-acting, very powerful diazepam derivative or something like this, and the next day women do not know what happened. They can now pick not just 1 month, they can pick 2 days. It's so sensitive. And actually, a very famous case in Germany 2 years ago, when parents who took kids from school at 4 o'clock in the afternoon daycare had the impression that the kids are dopey and drowsy, to find out by this test that the caretaker doped them with barbiturates so they will sleep, so she have less work. So this was picked up by these tests. So these tests are moving dramatically by the forensic scientists, but it's a fantastic tool for us to learn what happened in pregnancy without doing all these studies that will never succeed, and we continue them.
Thank you very much. Very, very great talk. I wanted to ask a question, or more of a comment about the bioequivalency discussion. Inherently, when you're comparing a generic drug to a reference, the main question is really a formulation. Do these two formulations, are they equivalent? So, so the regulators, that's really how they look at it. So they don't, from my understanding, they may see that if you are just testing the formulation, being is this formulation A equivalent to B, I think gender may not be something that they address. So that's my first. And the second comment, if the issue is variability rather than a physiological issue with absorption, would then the result of doing a study in women would just mean that you would have to have a larger sample size?
Yeah, very good two questions. I think they were addressed by speakers, but I'll kind of repeat. Of course, you need equivalent formulations, hopefully to get the same systemic exposure. But at the end of the road, you take a number of individuals that the government tell you or the guidelines tell you, let's say 20, you give them the drugs. The Chen paper is important because they had access to the FDA data. Say they took a drug like cimetidine, and they say, let's look if they took, of course, for the regulatory process, if the new drug that come to compete with the reference drug has between 80 and 120% of systemic exposure over time, it's okay. But you know that an average can include two different studies with very different variability. So if the 20 women had variability of 50% around that mean, whereas men had only 20% variability, you realize that there's more variability among women than among men. Yes, at the average is okay, but you know, average can be fatal, because it's the extreme end that may be poisoned or have less than they need. So the point here is this: if there are differences in variability between men and women, by constructing different groups of how many men or women, you decide your variability, and you never know if they're equivalent. So when I see a drug studied for pregnancy or for women with 20 men studies, it tells me the variability among 20 men. If 20 women were chosen, as shown by Chen, in quite a few cases the variability was much larger. And then it means that maybe it's not an appropriate dose, or maybe you need larger sample size. I don't understand why men should be used. Why? Young men and young women are as healthy, and it's just an inherent error in my mind in continuing. And we have to change habits which do not make sense.
So, I agree with you. If it's a drug that's to be used by women, they should test women.
Yes.
But I think, as we said, the system, the way the CROs are functioning, it may not. My last point, though, the variability. Do you believe that this is formulation-dependent variability or drug-related variability?
No, I think it's not formulation. I don't think so. I think if you take the same formulation and give it to men and women, you will see different variabilities coming from the many differences we mentioned in physiology, in metabolism, between men and women. And Dr. McGilvary gave the example of alcohol, which is studied more than any other drug for obvious reasons. The problem I have is, if drug X is to be studied and it was never studied for variability, I cannot even make assumptions from previous drugs. I don't know. So use it only on women, so I will know what to expect in women.
Just another comment about this is that we already know that in pregnancy that we are pretty sure that there's going to be changes in our hepatic blood flow, which is going to impact your bioavailability and inside pregnant women, and so there'll be even more variability between, let's say, generic versus brand names, because the rate of delivery to the liver is going to make a big difference. And so especially even in the case of biliary cirrhosis, there's likely some differences inside the transporters as well as differences in hepatic flow. So even using healthy individuals may not reflect what's happening with the patients. Like I said, just slight changes in the formulation can make huge differences in these populations.
That's right. I totally agree. And as you might have read recently, for antibiotics produced by fermentation and by biological processes, even if it looks like the same bioavailability, when you test it on bacteria sensitivity, it's not. So the topic of bioequivalence is much more complex than people think. And I don't see any why to use men and women mixed, unless the drug is used in men and women. If it's to be used in women for morning sickness, for pruritus, contraceptives, as Dr. Lalonde gave the best example, we try to give as low as possible oral contraceptives. Imagine that the variability change. You need to know that.